My name is Dave Rosenblum at AABP Pain Care in Brooklyn, New York, and I'm going to give you a little idea as to how I approach shoulder pain. Typically, patients who suffer from chronic shoulder pain either come from the internal medicine physician who really hasn't done much to work them up, or from the orthopedic who's done his steroid shot and doesn't think steroid is surgery is indicated, and maybe did surgery, and the patient still has pain. At the end of the day, the shoulder joint's a very complex joint compared to the knee, which is a hinge joint. The shoulder joint's not only a ball and socket joint, but the humerus, the head of the humerus is basically up against the glenoid with the labrum as like a cuff around that to hold it in place, which could be susceptible to tearing. The rotator cuff tendons all over it. The idea is to keep the head against the body, but enable range of motion in almost any way you can imagine. As you know, the shoulder is like, if you've ever had shoulder pain, it can be devastating because it's not just pain, it could be lack of sleep, especially if you're a side sleeper, and lack of the ability to use your arm. So classically, when a patient presents with shoulder pain, the question is it coming from the joint, arthritis? Is it coming from the bursa, which is related to the arthritis? Is there an impingement syndrome, meaning when the patient's raising their arm up over their head, or if there's any inflammation at the top of the humerus below the acromion by the bursa, causing restriction and pain of the motion of that humeral head and its rotator cuff tendons moving underneath the roof, which is the acromion. That bursa there is supposed to minimize the friction. So the bursa may be a target for therapies or a cause of pain, as well as the tendons itself. They can be susceptible to tears and rupture. And tears generally, if it's not a full rupture, do not need surgical intervention. It can be managed with physical therapy, strengthening the muscles of the cuff, as well as the ability to you could do steroid injections to reduce inflammation. But the problem with steroid injections are they just reduce inflammation, which can be enough. And when I threw my shoulder out, I had a steroid injection. It did wonders. I was I was limited. I was doing pain procedures. I had to do epidurals with my hands on a patient's back, and my medical assistant had to lift my arm up just to place it on the patient's back. I was so debilitated that I did a steroid injection, and within a day or two, I was back to 100%. Now, steroids, just to remind you, they work by reducing inflammation. They don't do anything for healing, but the body generally heals on its own to some degree. Just because you have a rotator cuff tear in the spine, just similarly to the idea of just because you have a disc herniation, does not mean you'll have pain. Meaning, if you take asymptomatic people, you do MRIs on their shoulders, many of them will have rotator cuff tears. They don't need surgery. They don't need shots. They don't need anything because they don't have pain. They probably could benefit from good physical therapy, proper posture, which keeps the shoulder back to protect the actual rotator cuff and joint. When the posture is proper, the joint and tendons are protected against further degeneration and tearing. But when we have tendinopathy, one option, or rotator cuff tears, which is a tendinopathy, the steroid injection is one way to go. Platelet-rich plasma or regenerative therapies are another way to go. The advantage to the steroid is you'll be better quicker, but it doesn't heal. The body will heal on its own to some degree. The platelet-rich plasma or other regenerative therapies, generally speaking, actually provide longer-term relief for many of the patients, but it takes 3 weeks to 3 months to start working. So if somebody needs to get back to work this week, the cortisone shot may be the way to go. However, if somebody's chronically suffering at a low level of pain and they just want to heal the injury, I would then generally recommend the platelet-rich plasma. Anyway, what happens when a patient presents with shoulder pain and I only have an X-ray or I don't even have imaging? What do we do? Well, I'll add to that. What if they do have imaging? What do we do? Well, one of my first go-to injections is the suprascapular nerve block. This nerve block is blocking a branch of the C5 and 6 nerve, which ends at the shoulder. It doesn't go down the arm. And by using an ultrasound to find the nerve, we can place local anesthetic, usually 5 milliliters of local anesthetic, with a small dose of steroid. And in fact, you don't even need steroid. There are studies performed. I don't remember the exact reference, but it was in Regional Anesthesia and Pain Medicine Journal that says patients who received only local anesthetic received almost a year of pain relief. I mean, just blocking the nerve to the rotator cuff, to the supraspinatus, infraspinatus, and 80% of the shoulder joint, that's what suprascapular nerve innervates, 80%, you can actually get long-term relief. For a variety of mechanisms, one might be the interference with any sort of restrictions from the pain because you're numbing the nerve. Others can be some sort of, I call it paradoxical motor improvement, meaning you block a nerve and you would think it would make someone weaker, but no, they're able to move their arm fully because of you're turning the pain off. Many people who can't get full range of motion, it's not true weakness, it's just poor effort due to pain. So if you take away the pain, then they can move through that full motion. And the other advantage to this block is, unlike a cortisone shot, you don't need cortisone. So in the brittle diabetic, the elderly, the patient with osteoporosis, it's a great nerve to inject. So what happens when patients do not respond to the steroid shots, to the nerve blocks? They don't want surgery, or they had surgery, or the surgeon thinks they're not a candidate. Because of course, surgery could fix the problem, could also create other problems. But generally speaking, it's still acceptable if somebody has refractory rotator cuff tear. Send him to a surgeon, let him do his thing. Unfortunately, a minority of those patients will come back with pain, and I take care of these people. First of all, reevaluate the diagnosis. Was it something else? Was it a cervical radic? Was it some sort of other nerve impingement, such as the suprascapular nerve getting impinged? It can be many things. So what we can offer these patients is also a peripheral nerve stimulator. By stimulating the suprascapular and the axillary nerve, you can actually get a lot of good relief, and you could give long-term relief from a short period of stimulation. There is a 2-month device that stimulates the nerve. It's invasive by needle, but there's no incision. And the patients will typically get relief longer than the duration of stimulation, because what stimulation does is it not only stimulates the nerve to reduce pain, but it also strengthens the muscles of the rotator cuff. Strengthening those muscles holds the humerus in place, especially during activity. And that stabilization actually reduces pain. You could also have a permanent stimulator implanted, which is basically a wire from the nerve, then goes subcutaneously, and an external battery goes on a sticker, and that provides electrical current to relieve pain. So there's really so much good you could do for these patients that many referring physicians are not even aware of. Orthopedics, not all of them know about this. And I think with proper considerations of the big picture, with the options, you could try to avoid the more invasive procedures and alleviate your patient's pain. I've been, unfortunately, doing pain management for long enough to see so many post-operative pain cases, whether it's spine, shoulder, knee, that I'm not seeing an unbiased view of the population. I'm biased. I'm seeing the ones that don't turn out right. The people who get relief don't come back to me. So my view is very biased. So I'm very careful as to who I send for surgery. And I'm very considerate that if I can avoid surgery for a patient who has a problem with a chronic pain issue, such as a tendinopathy or disc herniation, et cetera, I will try my best to avoid it. And if I send a patient to a surgeon, it means they really need surgery. So if you want to talk to me to know more about all these therapies I just mentioned, or if you're a patient who has more information questions, feel free to come to AABP Integrative Pain Care in Brooklyn, New York, 718-436-7246, or you could check us out on our website, www.aabppain.com. And thank you.